Thank you for the invitation to speak about this topic, which I'm interested in, the cardiogenic shock. When we are speaking about cardiogenic shock, we are speaking about a disease with 50% mortality, and this is the higher mortality than any other types of shock, including septic shock. What I want to highlight it here that we need to jump on this patient as fast as we can, because every 1 hour delay in the escalation that associated with around 10% increase in the risk of mortality. Typically, when the patient presented with hypotension and cardiogenic shock, we go ahead and just start pressors to these patients to get blood pressure pretty good. But the case here, or the fact that cardiogenic shock without inotrope, the survival rates is around 68%, and it drops to 35% with 2 to 3 pressors, and it's only 26 survival rates with 4 pressors. So adding pressors decrease actually survival in cardiogenic shock. My job today is talk about Impella indication in cardiogenic shock. There is another indication in high-risk complex PCI. Basically, we have 3 types of Impella: Impella CP, Impella 5.5, and Impella RP. Impella CP, it's 14 French. We insert it percutaneously. It gives support up to 4 liters to help LV. Impella 5.5, same concept, but it's quite bigger. It's 21 French. Put it surgically only from the axillary artery in the most of the time. Impella RP, this is for the right ventricle, although it's 23 French, but we put it percutaneously. So this is a case of a patient presented with shock and infralateral myocardial infarction, proximal LCX thrombotic occlusion, mild disease in the LAD, depressed LV ejection fraction 20%. So based on this data, we go ahead and we inserted Impella even before PCI. And this, with the Impella support, we go ahead with the mechanical thrombectomy, stenting, and this is what we had at the end of the procedure. Then the patient went, of course, to CCU with ejection fraction 25, severe mitral regurg. Luckily, we could wean from the pressors in the day 3, Impella in the day 5, but the patient complicated by pulmonary edema. We did clipping for his mitral valve, and the patient improved discharge after 2 months. One more case with a cardiogenic shock, again with extensive anterior myocardial infarction, again severe LV systolic dysfunction and increased LV-EDB, mild disease in the RCA. LAD is completely occlusion, left main disease, LCX is almost subtotal. We thought we can go ahead and did balloon stenting, and this is what we had. But suddenly patient had severe bradycardia plus asystole cardiac arrest. So we called for the VA ECMO. We put the ECMO in the cath lab with, of course, with TPM. And we shifted the strategy for multi-vessel PCI for revascularization. We did left main, and this is what we had at the end of the procedure. But at the end of this procedure, we put the Impella. This is our practice in my center. We inserted Impella with the ECMO for the LV unloading. There is a lot of benefit, as mentioned before, with Impella, with ECMO, because ECMO increase the afterload. So we put Impella to unload the loaded left ventricle. Patient went to CCU. His course complicated by brain infarction, improved little bit clinically, tracheostomy, and we shifted him back to his local hospital for further management and rehabilitation. This is his echo at admission and at discharge, improved from 25 up to 45. I'll speak about the Impella CCU management because this is as important as inserting the Impella. We have a patient check-in list immediately upon arrival to CCU. We check for the insertion site, and my recommendation here, to keep the angle between 30 and 45. We put a gauze inside the cheese. This is really decreasing the bleeding from the insertion site. Again, we check the extremities for the ischemia. We look for the Impella parameters, P level, per fluid, and flow. We do baseline echo and X-ray, and this should be done daily. This is the Impella CP correct waveform. We have the red line for the aorta, the white line. This is the calculated left ventricle. This is not the actual left ventricle because there is no sensor at the inlet. The sensor is only in the outlet. The green line, this is the motor current. This should be pulsatile as you see here, because if it's flat, that means two things: either the patient is really sick or Impella position is incorrect. Two important alarm to have. We need really to be focused: suction alarm, the yellow alarm, and red alarm related to the position. Position alarm, either the Impella is too far inside the left ventricle, or the other possibility, the Impella is completely in the aorta, and we need to fix this to secure or to guarantee that the Impella is doing its job. The yellow alarm, this is related to the suction, and its three possibilities: either incorrect position or inadequate LV filling, RV failure. If you have the yellow alarm, check for these three possibilities. 4 mole parameters to be monitored even every 8 an hour in the CCU. This will monitor your escalation and de-escalation plan and put another plan for weaning. Cardiac power output, happy for the right ventricle, pulmonary artery, pulsatile index, and lactate, plus of course urine output. Cardiac power output, this is really important. Our target more than 0.6. It can be calculated by the Impella. Happy for the right ventricle. Our target more than 0.9. My last case, this again patient's cardiogenic shock, but referred from local area hospital with intra-aortic balloon, subtotal LED, diseased LCX. So we did a PCI, left main, proximal LED, and proximal circ. Patient shifted to CCU, but unfortunately, one day he had VF, VT cardiac arrest. We put the ECMO bedside, then shifted again to cath lab for relog. And there we go. We have the completely occluded stent. We had the ECMO, so we did PCI, left main, LED, and circ. Again, as our protocol, we did Impella for venting the left ventricle. Patient, this is our final result. And again, my recommendation regarding the Impella or Expella, ECMO with Impella, no need for high performance or P level in this case, because B4 and B3 is really enough in this case until we start to wean the ECMO. Then Impella in this case becomes the primary support. Then you can increase your B level. This is the patient then went to ICU, actually long and complicated weaning course. But I want to mention here that his weaning course we put 5-5 and replaced ECMO and Impella as a bridge to recovery. Patient luckily discharged 50 days after to his local area hospital for more rehabilitation. So my conclusion, ladies and gentlemen, early presentation make dramatic difference in cardiogenic shock. Rapid escalation to mechanically support and between mechanically support. This is a case, or this is the key to improve end organ damage. Initial lack of pulsatility does not mean all is lost, as stunning can take some time to recover. Thank you very much.